for our conversation, about children and youth behavioral health. This is a pretty remarkable panel, if you didn't know, in front of you, and I'm really excited about this conversation. So I'm Chris Stoner-Mertz. I'm the CEO of the California Alliance of Child and Family Services, and I will be moderating this exceptional panel, and I'm going to just turn it over to everyone. For those of you who don't know the Alliance, we are an association of 160 nonprofit community-based organizations that do work with children, youth, and families across the state. And our members are in every county, some working with all of you in the health plan world, and also working a great deal with the mental health plan, the public mental health plans and counties. So I'm going to turn it over to Melissa Stafford Jones.
Good afternoon, everyone. Melissa Stafford Jones. I'm the director of the Children and Youth Behavioral Health Initiative with the California Health and Human Services Agency.
Good afternoon, everyone. My name is LaShawn Francis. I am with Children Now, a research policy and statewide advocacy group.
Buenas tardes. Woo! Now it's on. That was just to make sure that you are paying attention. My name is Jackie Tu-Hung Wong. I'm the executive director of First Five California, and so excited to be here. That's it, right? And so it's my favorite place to be, right after lunch.
All right, we've got a couple of slides. There's us. Let me start by just getting a sense of who is in the room so we can make sure that we're addressing what your interests might be. Curious, how many of you are actually working in the children and youth behavioral health space? Okay, good amount. And how many are working with a health plan or in the health arena specifically? Great. Physicians? Nurses? Community health workers? Okay, great. We've got a really nice mix here. That's excellent. This first slide we put together really because we wanted folks who maybe haven't been in the children and youth behavioral health world to see all of what is happening in this world, because it's a lot. There are many, many initiatives. We're gonna dive deep into one of those that Melissa is overseeing, the Children and Youth Behavioral Health Initiative. But there are many other ones that are really impacting the world of children and youth in our public systems. So I know all of you know well CalAIM. There is a component of CalAIM called the Foster Care Model of Care, focused on how do we ensure that foster youth specifically are getting their medical and behavioral health needs met. You are also very likely aware of the ACEs Aware initiative and the focus on provider trainings related to screening for trauma. The Family First Prevention Services Act is something you might not be so aware of if you're in the health world, because it's really focused on child welfare. It is a national movement to reform the way in which child welfare works, with a focus on providing prevention services to families who are at risk of their children being in foster care, as well as reducing the number of foster youth who are in very intensive residential programs and reducing the time in that care and really focusing on getting them back with family. Of course, a lot of what's needed to ensure that the vision for this happens is you need behavioral health services for those families, right? So that is in some ways adjacent to a lot of the work that I know you all are seeing through CalAIM, but these things all intersect. And similarly, the 1115 waiver that is in process of discussion and that DHCS is working on also has elements of services and coordination and incentives that will impact foster youth as well as youth in the juvenile justice system. Finally, and I won't go into the Children and Youth Behavioral Health Initiative because Melissa's going to give you a lot more detail on that. You've seen probably a lot of information coming out from the governor and through HHS around investments in behavioral health in schools. Lots of partnerships with managed care organizations through SB HIP, Community Schools Initiative, $4 billion committed to that to ensure that schools are being seen as a hub for these behavioral health services for children and youth. All of this to say, that is a lot going on impacting this world of children and youth. And what's key, and this is going to be our conversation today, is how do we ensure that we're all really working together towards the larger vision? What are the things we need to be watching for? How do we ensure that we're not just putting a whole lot of things on paper, but we're actually addressing issues like equity? So I'm going to turn it over to Melissa, and she's going to give you a walkthrough of the Children and Youth Behavioral Health Initiative.
Great. Hello again, everyone. Thanks for being here with us for this conversation. And I love that slide, Chris. And I think I'm going to start off with last summer, Governor Newsom announced the Master Plan for Kids' Mental Health. And in many ways, the construct of the Master Plan for Kids' Mental Health is aligned with the slide that Chris just showed you. Really was a very intentional way of the governor saying, we are going to have an all-of-the-above transformative approach to how we support the well-being of children and youth, with the recognition that we need to be acting across multiple sectors and systems, including schools, including behavioral health, including physical health, including workforce, that all of these relate to the behavioral health and mental health and well-being of our children and youth. And so that frame is really the frame in which the Children and Youth Behavioral Health Initiative is being developed and implemented and ultimately will operate. I regularly say that I will have failed in my job as the director of the Children and Youth Behavioral Health Initiative if it does great work, but it does great work and it's just another silo. Or it's just another silo of another initiative that is not connected or aligned with other related initiatives working to improve behavioral health and well-being for our kids. And so part of our collective work is, in fact, to determine at both the state and, of course, in California at the local level, how it is that we think about the opportunities for coordination, for integration, for centering equity, for really putting the needs, the voices, and the strengths of our youth and families at the center of the systems that we are developing. And that is our work in the Children and Youth Behavioral Health Initiative, but it's also our collective work across all of these initiatives in the Master Plan for Kids' Mental Health and the broader work that Chris mentioned. So what is the Children and Youth Behavioral Health Initiative specifically? It was passed by the legislature and signed into law by the governor in 2021. It's a $4.7 billion 5-year initiative that really seeks to reimagine the ecosystem of behavioral health services and supports for all children and youth ages 0 to 25 in California. It is really focused on building a more coordinated and integrated system, a more youth-centered system, an equitable system, and a system that focuses on prevention, well-being, positive mental health, and early intervention. The initiative does address the full range of supports and services that our children and youth may need, all the way from that work on positive mental health, well-being, resilience, all the way to, as Chris was talking about, making sure that our youth who are often system involved and have the most intensive clinical behavioral health needs are getting access to the supports and services that they need. We also know, though, from our partners and from children, youth, and families themselves, that because of our silos, we often miss opportunities, though, to intervene earlier and provide support earlier. We have been doing a lot of work over the last year in the Children and Youth Behavioral Health Initiative, really hearing from youth and families, and one of the things youth have said loud and clear is, do not wait until I'm in crisis to provide me with supports. And youth, as I'm sure you have heard, tell many stories of being told, essentially, you're not sick enough for us to help you. And they are asking us to change that. And I'll mention a couple of recent reports in the course of a few opening comments here today, but one of them is we released a report last week called Youth at the Center, which is really a synthesis of what we have heard from youth families and communities over the last year through a series of focus groups, which we did through Trusted Partners, by the way, because that's what people told us that we needed to do to really hear authentically from youth and families, and also a series of community engagement sessions across the state. And we synthesized the findings of what we heard from youth and families. And I hope it is a report. And Secretary Galley was very clear in his opening letter to the report that we intend it to be a guiding light for the work of the Children and Youth Behavioral Health Initiative, and I hope it's a report that we will come back to time and time again when we are trying to drive forward this work of how to develop a more youth-centered and equitable system together. And then speaking of the together part, another report that we released just yesterday, and there are people both on the dais here and in the room who were major contributors to this report, is what we call the CYBHI Ecosystem Working Paper. And I know it's a mouthful, and it is a working white paper. I often refer to it as a working paper with coffee stains. It's meant to be the kind of report that it's not that it's necessarily full of answers. It was based on over 100 expert interviews and research. It was written by Breaking Barriers. The work was coordinated by Breaking Barriers California, a whole child education policy group. And the findings from the report were really about, our partners said to us, Melissa, this is a great vision that the CYBHI wants to create a more integrated system, a more equitable system, but what does that look like in practice? What's going to be any different than what we do today? And so we asked Breaking Barriers to talk to all of our partners and say, help us articulate that. What would actually be different in the functional capabilities of how the system operates and what it is capable of doing in terms of how it coordinates? And so that's the findings from that report. So I also really encourage folks to review that report, to engage with us. We want it to be a living document that helps us drive forward how we really put into practice how we coordinate across systems and sectors to really center and meet the needs of youth. Another really key aspect of the Children and Youth Behavioral Health Initiative that Chris also touched on is meeting youth where they are. And that in addition to home and with family, we know the other place where children spend the most time is at school or in learning settings for our youngest children, childcare and preschool, in K through 12, and for our older youth, including higher education, but certainly not limited to that. And so an important part of the work of the Children Youth Behavioral Health Initiative is really supporting the school health partnership in a multitude of ways, which we can talk about a little bit more, but that is a core aspect of the Children Youth Behavioral Health Initiative, is meeting children and families where they are in order to deliver the kinds of services and supports they're telling us they want and need to support their well-being. I've touched on most of these ideas, so I'll really, in the interest of time, leave this slide for your reference. And then I promise not to go through this whole slide, but I wanted to share it with you. And I think these will all be shared through the app for the conference because they were sent ahead of time. But the CYBHI is a large, complex initiative. It's got 20 different work streams in it, but they really do fall into 4 core areas. The first is a very strong focus on building the behavioral health workforce we need, and that includes more behavioral health workforce serving children and youth, a more representative workforce. We heard directly from children and youth. They want to interact with providers who look like them, speak their language, understand their experience, and come from their community. They're very clear around that. And we also recognize that Many folks who might not think of themselves and who may not be technically a behavioral health provider are actually really important people, though, in child-serving systems to support the well-being of children, and we need to support those adults who are doing that work, including our educators and other providers as well. Many folks in school told us, sometimes it's the bus driver or the school custodian or the yard duty supervisor who is the most important person who knows what's going on with our kids. So how do we support them with different kinds of training and supports? The second area of focus in the initiative that a number of the work streams fall under is really in developing the infrastructure we need across this more coordinated cross-sector ecosystem. And that falls into several areas. One is just bricks and mortar. We know that we need more of certain kinds of capacity of behavioral health services for our youth. And you may have seen some announcements about that in December, really significant investment of about $480 million specifically in capacity of services, behavioral health services for children and youth. Another is in partnership. We can't have a more collaborative, integrated system if we don't have partnerships, if we don't resource and support those partnerships across different parts of the system that often historically have not worked together. So really investing in that kind of collaboration and partnership in a way that supports that becoming not just a great thing that sort of happens sometimes when there are great leaders, but really becomes embedded in the way that our systems work. And that's partly related to that ecosystem working paper that I mentioned, providing some direction about what would it take to actually accomplish that. We also know that another place kids are spending time is online, and that is also a point of accessibility for services and supports. And so the development of a virtual services platform for children and youth, but also a component of that is for clinical providers to get supports for meeting the behavioral health needs of their young patients, is also a part of that ecosystem. And the last thing I'll mention in this sort of infrastructure category is the scaling of evidence-based and community-defined evidence practices. We know there are a lot of incredible practices in the field that are already making a difference for our kids' behavioral health, but what we often hear is they're very hard to sustain and they're hard to make systemic. So we're investing in how to scale those, how to provide grants to scale those, and then really thinking about the sustainability through the work of the Children and Youth Behavioral Health Initiative and some of the other initiatives that Chris talked about. The third category is really around coverage architecture, which I know we've got to come up with a better name for that. It's just gobbledygook, technical speak. But the big important piece here is that the Children and Youth Behavioral Health Initiative is for all kids, and it's an all-payer initiative. So as part of this work, we are developing a new fee schedule for school-linked behavioral health services that will apply to all players, both Medi-Cal managed care plans and commercial plans, to both increase access to needed behavioral health services and supports all the way from prevention to one-on-one treatment for youth in a school or school-linked setting, with the ongoing engine of resources to support those through a managed care reimbursement. And then lastly, as you can see on the right hand of this chart, we have heard from youth, we have heard from families. Stigma remains a barrier to our youth getting the services and supports they need. Sometimes amongst each other and in their own age group and their own community of peers, but also with their families and their communities. And so really thinking about how in a way that is culturally competent, that is grounded in trusted partners helping us to shape the work and the message and the outreach to continue to take on this issue of stigma so that we can really address both access but also disparities that we know we have in terms of behavioral health services. And then the last report I've mentioned to you, the Youth at the Center report and the ecosystem working paper. The other, and I have physical copies of this if anybody actually wants to re-enter the world of paper, and I know some people do and some people don't, but I have copies. We did a progress report in early January, just sharing our activities up to date of the first 18 months of the Children and Youth Behavioral Health Initiative, but also previewing some of the key markers of next steps we'll be taking in the next 6 months. And then this is more for your reference. This is how you can access different information about the Children and Youth Behavioral Health Initiative, as well as how you can access specific information through different departments that are leading these different bodies of work. And we are working on a new CYBHI website to start later this spring that we will hope make it easier for our partners to access the information that they're looking for about the initiative.
Thanks, Melissa. You may have said this, but just to make sure that everyone knows, what is the time frame for the CYBHI?
Yeah, it's a great question. It's a 5-year initiative, and each of those 20 work streams has its own timeline. Primarily 2022 for most of those work streams, which was really the first full year of the initiative, was focused on research, partner engagement, design, planning. Many of the work streams have already started to move into implementation, and more of them will continue to move into implementation mode this year. We do have a CYBHI 101 slide deck on our website that for each work stream, it describes sort of the basic timeline for it. But yes, they're each on their own timeline, and we will continue to do partner engagement through each of the phases of the work, including engagement with youth and families.
Fantastic, thank you. I'm going to pass it over to start with LaShawn, and really to just ask you, what are the things that, having learned and been very involved, helping write the paper, with the Children and Youth Behavioral Health Initiative, what are any, and you can broaden that to the larger children's initiatives, what are the things that give you hope?
Jackie, thank you. So the things that give me hope, I would say primarily, okay. I'm not even sure if I need a mic. No one has ever told me I wasn't loud enough, so we'll go from there. So my experience has been that the young people who are talking about mental health, they are the bright light and the bright spot in this work. When I was growing up, we never talked about mental health. We never referenced it. You were either crazy or you weren't. There was no thinking outside of how your world impacted your emotional well-being, right? And as a matter of fact, it did not exist unless you were visibly sick. So I love the fact that young people are talking about it. You can't get them to stop talking about it on Twitter and TikTok. I mean, there have been times when I have felt awkward watching them talk about their mental health because it is so different for me and different from the way I was raised, right? So even stepping outside of my comfort zone to ask them what it is that you want, what is it that you're seeing, what is it that you're experiencing, and how is that impacting you? And so that has been really exciting. The thing that I'll say though is when I really think about it, not much has changed except for the fact that young people are more blunt and direct in their communication and their speech. So I say that to say it has not been a secret since, as my mom would say, Jesus was a boy, that police violence against Black people has been impacting their mental health. And that has been said in various ways, in various means since the beginning of time. So we weren't really listening. And now we're in a space where I think many of us are willing to listen. But it's not a new conversation. So I really want to draw that distinction about the fact that many of these conversations are old ones. Young people are having them in a different way because they tend to be more direct, and then with the access to social media, we all tend to hear them out instead of just people in the Black community hearing them, or just people who interact with certain communities hearing them. So that's the primary difference. But I don't want to make it seem as if this is news, because it's not really newsy. This is something that has been going on for quite some time. So that's what I'll say gives me hope, gives me excitement, is that young people really are leading the charge and being quite blunt about what they want. The question now for me is what we as the adults in the room who have the quote unquote ability and political power will do about it. And I think that's what concerns me the most, is whether or not we have the political will to do the things that young people are asking for.
Thanks, LaShawn. We're going to get to those concerns for sure. Appreciate your getting us prepared for that piece of the conversation. Jackie, how about you?
Yeah, no, thank you for that. I learned a new phrase. You'll appreciate this. As somebody said, you live long enough, you'll see the back of your head. Like, before y'all came in here, Chris, I, and LaShawn was like, remember when we had that conversation 20 years ago? Right? So for me, I'm a provider. I'm a consumer. My kids are consumers. That is really unheard of, right? Like, anybody in the audience speaks Vietnamese? Okay, a couple of you. What do we call the mental health facility? Yeah, crazy house. Literal translation in Vietnamese culture is crazy house. So a lot of this is, to LaShawne's point, is that we are taught to oppress these feelings, this trauma that comes up. And I'm a refugee kid. You know how much trauma comes through, like in utero, by the way, right? Like comes through in utero, prenatal, and all of that. And my parents' generations are just told to suppress. That manifests itself. And as we know, ACEs, the toxic stress that happens, right, manifests itself in heart disease, kidney disease. I have a family history of kidney disease. People don't know why. I think I know why. Right? The science is there. Right? So for us, we had the privilege and honor of having the first Surgeon General, Dr. Nadine Burke-Harris, as our chair for the first 5, and we actually doubled down on the ACEs, right? What does that mean? Like the adverse childhood experiences, and there's always been this concept in the community, like, so, but what do you do about it? Once you tell people, like, what? Yes, I knew I was traumatized. Yes, I knew, that war and seeing all that really, what I really loved about the research, the conversations with our North Star that led us to, our North Star being that we believe that trauma-informed, healing-centered, and culturally responsive systems create the safe, stable, nurturing relationships environments necessary for children's healthy development. Right? That's the script. That's the script. That's the treatment to ACEs, right? Safe, stable, nurturing relationships environments, right? It's not a new conversation. It is old as time. What did you say? Older than Jesus? When Jesus was a boy. When Jesus was a boy. When Jesus was in utero with Mary, right? So just really loving that, like, yes, my children are more direct, and I had to be honest, be brave and break against my family's notion of what behavioral mental health was. If that makes sense. And part of my journey is also I'm a trained social worker. One of my biggest career regrets is I never sat to get my license, even though I have my hours. But I will go back one day to get that license. But working in West Oakland and Oakland, being in every single group home in Oakland, right, providing treatment, it is eye-opening, right, about the system of care or the lack thereof, right? And when we think about this for youth, and we often kind of, as a provider, it's easy. We have treatment, we have modalities, we have a focus on youth. Now I'm here at First 5, there's a preventative opportunity in this conversation that I'm really excited about the conversations I've had with Melissa, right, about even just yesterday, I'm like, Melissa, we're doing this. I can't really tell you, but really, we're about to change the water, right, the FSG, the waters that we swim in, right, together collectively, and just can't, we can't get there fast enough, right? And so I'm just really excited about this vision of transformative culture, of really doubling down on what we've always knew worked, right? The access to behavioral health care, just kind of culture responsive services. And that's a hard nut to pack because we live in systemic racism and bias every single day. People don't want to name it because it's hard to actually kind of try to figure out how do you, like even what I shared with you, what is culturally responsive for Vietnamese refugee, Vietnamese American women, right? What does that mean for my parents? What does that mean for my children, who, by the way, ask for therapy all the time? Like, you don't need therapy just because I didn't give you a Rice Krispie. It's okay. But maybe that's a little bit insensitive.
Don't minimize their experience.
I will not minimize their experience. See? I do not. But then, anyways, so a little bit lighthearted. So that is my hope, my vision in terms of this preventative measure, really leveraging the opportunities of FFPSA, what First 5 California is focused on, what you are focused on, what Children Now has been, Chris, like, it's just this conversation of, like, how do we crack this nut, right? Because I also work for the National Center of Youth Law, who did KDA, right, and implementation of that, so I have a deep knowledge of what is right and just for our babies, and we can give it to them through this initiative.
Thanks, Jackie. And Melissa, I know, you're out here talking and in many ways marketing this, but you must think about things you're most hopeful for too, right, around the initiative and some of these other things happening. What's that for you?
I think there are a couple of things that give me hope. And one of them is something that LaShawn talked about, which was just the youth and their engagement in the work. Both their sharing of their experiences, but also the ways in which they are interested and prepared and willing to take those experiences and literally help use them to shape the work that we are doing. You may have heard my colleagues at the Department of Healthcare Services, for example, who are designing the virtual services platform say, like, we're not designing a platform with the idea, like, if you build it, they will come. We're designing what youth tell us they want and need out of this kind of approach. And so that gives me a lot of hope, because the level of engagement we've had from youth and parents in the initial stages of developing and designing the work of the CYBHI has just been incredibly powerful. And broad. I mean, they've said to us, we need to redefine what treatment is, to the points that were just made here. Like, in their mind, caring relationships, art, access to outdoor space, being involved in clubs with their peers, these are all treatment. This is what they're telling us. This is how you should define treatment. The way culture is healing. They've said to us, you have to think of culture itself as part of healing. And you need to focus on building a more healing system, not just a better system in general. One of my favorite quotes from one of the youth is, you can't call it a mental health system if you only focus on helping me when I'm really sick. Yeah. Like, even the words we use, right, they question. So that gives me hope, because I just think it's so powerful. And then the other thing that gives me hope, they're interconnected, is we have 20 work streams and $4.7 billion and policy change that goes with it to make some of this real. Are there issues and changes that are needed that maybe aren't encompassed in that? I'm sure there are. But we have policy change, programmatic opportunity, and funds to go with it to utilize in the next 5 years to make a transformative difference. And that gives me hope, because I think part of the reason why sometimes it's maybe been more talk is there was not always the opportunity to put resources and policy change to what people's ideas were. And we had a moment in time in 2021 where that became possible to line all that up. And so here we are together doing that work. And the other piece of that gives me hope, but candidly also falls into the concern bucket, is that requires us to do things differently, to change. And we know that systems change is one of the hardest things we all work on, because systems operate the way they do, not randomly, but for good reasons. They were put in place with certain parameters, certain rules, certain funding, certain expectations, certain outcomes goals, certain ways they're evaluated, the way they operate. And the opportunity we have, which gives me hope, is we have this time to say, no, wait a minute, we're going to step back and rethink how we work across these systems in order to really center the needs of our youth. But that does require all of us to be a part of thinking differently about not only what we do, but how the systems we operate in function, and how they might need to be different to actually center youth and actually make changes in terms of equity, right? Because we know that inequities are held in place by the current power structures. And so unless we are disrupting some of those systems and some of those existing power structures, we are not going to be able to change some of the inequities that we are really looking to change, and that, as you all know, are very stark. All of our kids are affected by these mental health and behavioral health issues, but we do know there are some groups that are disproportionately impacted. But the hope I have is that there's a lot of energy and interest in people at the table to do this work. The challenge is actually making change that then we commit to and embed in how we do the work, not just sort of be independent based on sort of a more anecdotal approach.
Thank you. So let's get to, you started us off a little bit of what are the potential concerns, and also given our audience is folks, you know, that are really in the health, a lot of them anyway, are really in the health world. If you can kind of weave in, you know, you're thinking about what do we need to really be attending to as it relates to health, the broader health world, and how this gets connected. And we are going to have time for Q&A, just FYI. So we'll make sure we get 15 minutes if folks have questions.
Is that for me, for Jackie, or?
Both of you.
us? Okay.
You can
Shall
pick
we
your
do it
order.
together?
At the same
Yeah,
time.
let's sing a song or something. Can you put it in a phrase? Song.
So I think the way we've seen this is we are always pushing the state of California and our elected officials, our policymakers, to do the things that are hard, or to try to do the things that are hard, right? And that sounds easier than it actually is. I made a comment earlier about the fact that a big part of this is, do we have the political will to get some of this stuff done? And some of it is yes, right? I think the CYBHI is a really good example of that. Melissa talked a little bit about that virtual platform that young people are informing, and we're really excited to see what comes of it. But then there are other issues that you might not think are that complicated. Like, we've talked about how young people have said time and time again, art is helping them when it comes to managing their emotions and getting their frustrations out. And we have systemically and subsequently continued to cut art programs across the country and in the state of California. Art was so hard to fund, we had to put it on the ballot in November. Right? Like, that is what happened. Many of us voted for that ballot initiative, but that is essentially what happened. Young people said we would like art, and we said, maybe not. Maybe we don't fund art for quite some time, to the point where we need a proposition in order to do it. We are operating in that framework for a lot of things that families are asking for. The childcare fight has been happening for a very long time, and childcare does not automatically lend oneself to think about mental health, but you think about the stressors that people in poverty are experiencing, and one of them is being able to find safe, reliable childcare. You think about the stressors like, making minimum wage and being able to afford rent. All of these things are health issues because they impact how you feel, they impact how you think about things, they impact how you move through life. And essentially, we have chosen the things that aren't as hard to do politically to work on, to be frank, and we have left the other ones alone. But the reality is, until we are willing to tackle how our systems are racist, until we are willing to tackle how our systems oftentimes perpetuate poverty, we're not going to see a lot of movement no matter how much money we throw at it. So these are core issues that we really want the state to look at. How are we tackling racism within our healthcare system, within our education system? How are we tackling poverty? What does that look like? Particularly for a state like California that's so rich. Those are the hard questions. I don't think Children Now thinks that we have the answer, but what we do know is we know what the core problems are, and we are working on everything but those things.
I appreciate that. Can I just show, just by a raise of hands, how many people actually believe that there is a disparity issue in the healthcare system? Okay, that's pretty much everybody, right? And so, I want to challenge something, because you said, yes, systems were designed, but they were designed for the outcomes that we see today.
That's right.
Can we just admit that? That we know that Black families have a harder time getting access and have poor health outcomes. Let's just name it. And how do we unpack that as a system when we think about being really healing-centered? How do we remove those barriers in healthcare? How do we actually address the systemic bias, but our own, the humans in the system, right, who are just in the system, right, in education or healthcare or otherwise? That is something to unpack, right? So even when you are a provider in the system, I often have to think, am I continually perpetuating the thing that the system is creating? And I'll be honest with you, as a provider of color, I was bumping up against that all the time. DSM-4, ICD-9. I'm having to label communities, children of color, kids in foster care who are abused, neglected, poor, otherwise, so they can just have access to art therapy. And that is a label that perpetuates with them, because then the school knows. Then they treat them differently. Then there's a narrative that's created that is compounded, the intersectionality. Healthcare is an antidote, right? Like, let's just be clear that we all pretty much all raised our hands. We know that there's disparities in the system. We know that it's created off of racist ideologies. There are humans in them. So how do we create the political will, because we do have the collective political will, to say the thing, to do the thing, right? To begin to change our behavior. And I'm just admitting to y'all here in public, I think it's the first time I ever said, like, that was a challenge I faced, and perhaps why I didn't get my LCSW. Because it was challenging, really challenging, to say I had to find this thing, a book that used to say homosexuality was a mental health issue. That women who had hysteria during those times. Like, you really think about the history and what we are actually kind of built on. I'm gonna say it. White male, right? Straight, cis, white males, a male. I actually did my thesis on this. And so it is that concept of othering that has created the system by which we live in now. And that's just, we can't go back, we can't unravel it, but we can challenge it, right? We can think about what is evidence practice, what I always say, I'm gonna push for, what is practice-based evidence that we know? Because I was tired of having to label kids just so they could get access to the things that they should be entitled for, to address the poverty, the things that they were born into without. I'm sorry.
No, this is actually really good, because one of the things that Melissa had mentioned earlier was how young people really want culturally congruent, culturally competent care. And one of the things that we always talk about with workforce is how do we get more POCs into that space? But the reality is I'm meeting more and more young people who are actively saying, I actually don't want to participate in that system because I think it's harmful. So we're not challenging the system, we're asking people to enter it as is. We're not challenging the education curriculum. We're not challenging what it means to get your LCSW. We're not challenging those things. We're simply asking them to come into it. We're simply saying, we'll pay back your student loans. We'll do this, we'll do that, which are great things, don't get me wrong, but it's really not even touching on the fact that the younger generation at this point does not want to participate in harmful systems and actively are choosing not to. So
Older people too.
The older, you were considered younger. You were part of that.
I'm
you were
still
part of that.
considered young.
Yes, exactly. So people are actively opting out, and I think that's a conversation that we need to have. It's one that's often ignored. So, I don't know what to do about that per se, but we definitely need to have the conversation.
So I can't do a follow-up question?
Yes.
We put
And
a
what are
lot
we
out
gonna
there.
do?
Chris is supposed to moderator. I need a poll. We told you not to sit us
Y'all
next to each
are
other.
doing great. I'm going to ask Melissa to jump in.
I mean, on that particular point, then I'll share a few other thoughts, but I think on that particular point, I think we actually are hearing from young people on that, what they want. And I think one of the things we certainly heard was that, as I mentioned, they want to engage with folks from their community who understand their experience, particularly as a starting point. And so I think youth have been also really clear that they want more peer-to-peer supports.
Yeah.
And so I do think that's something we're working on in California in terms of really increasing the focus, including in the youth space, on peer-to-peer supports, both for really investing in particular in 18 to 25-year-old peers. We even allowed in a training program HCI did last summer that they funded 16 and 17-year-olds could be in the training so that when they turned 18, they could be a part of it. And investing in looking at some pilots around youth, high school peer-to-peer, so that we can think about what is really the structure we need for that to grow over time, given that that is something that youth are telling us. And then I think the near-peer model of the new wellness coach that we're developing in the Children Youth Behavioral Health Initiative is another place where we're saying, let's change the makeup of who is in the behavioral health workforce so that it can be more responsive to what youth and families are telling us they want and need. So it's not that it's a complete answer to that, but I do think we are working on not to your point, LaShawn, only sort of tweaking what we have, but actually being prepared to try some different things and see what we can learn from that and see if it will allow us to better serve children and youth. And I want to acknowledge, and we heard this directly, not just from youth, but also from families and communities and community engagement sessions we did around the state, which was that, you know, in one workshop, a young woman, I was actually sitting right next to her, said, you know, you guys could build the most wonderful, perfect, beautiful ecosystem, but I actually have to believe that it's for me. Because historically, it has not been for me, it has not been for my family, it has not been for my community. So you're gonna have to make that clear, and she and many other young people and community members told us, and part of that is acknowledging the harm that has been caused by the systems that we have. So CYBHI, for example, has an equity working group, and our definition of equity that equity working group just adopted a few weeks ago explicitly acknowledges the harm that has been caused and how part of equity work is acknowledging but also repairing that harm. So I do think that is a part of the work as well in terms of how we really address equity. That is what our youth and families and community partners have told us is a part of this work. And then the other piece is, you know, I think we do have an opportunity. I mean, I wish we could have even a giant slide bigger than Chris's with like even all the other parts, right? Because there is more, right? There are really important investments happening in expanding childcare. And that's not part of the CYBHI, but that's not important, right? What's important is that when we look at the totality, we are thinking about, to the point LaShawn made, the different levers that we actually know affect not only youth, but families' well-being, and how we are making sure we are thinking about how we tie those efforts together, and that we are thinking about them holistically, even if they don't need to be coordinated per se, that we are thinking about that really strong whole child, whole person approach that's part of the guiding principles of the work of the California Health and Human Services Agency.
And a lot of threads there with the vision of CalAIM and social determinants
Very
of
much
health
so.
and all of that.
Or, for example, right, like the change in CalAIM that youth no longer need a diagnosis in order to get services, which is meant to be, you know, responsive to that,
Yeah.
some of the concerns that were raised. So in lots of things in progress, and of course lots more work to do, but I think there is this wrestling with, and I think some good work happening around not just assuming that we're tweaking the status quo, but actually thinking about some of the more fundamental changes that we need to make in our systems to better support our children.
Outstanding, thank you. We could keep this going for an hour, but out to you all, questions for our panel, and I'll come around and do this thing. I see one hand here.
Put a lot out there.
She's gonna get her steps in.
Very loud too, so I want to make sure I don't blow everybody's. Can
Very
you hear me
good.
okay? Okay.
Yes.
So I want to apologize in advance for this question because it's very loaded. But so, you know, some other progression that, okay, excuse me. My name is Tony Amato. I'm a investigator for the California Department of Managed Healthcare. And so I've seen some progression in regards to Senate bills. So you have like Senate Bill 855, mental health focused, and then you have 221 with, you know, reoccurring mental health appointments need to be established within 10 days. We are nowhere near where we need to be. What's next? What's the next, like, if you, like, what do you want to see next come out from legislation?
So-
I told you it's loaded.
Yeah, no, it's actually not that loaded for me because we are sponsoring SB 283. So, so I can tell you right now what I would love. SB 283 would actually require that health plans, employer-sponsored coverage, if they deny children's mental health services, those denials have to automatically go through an independent medical review process for review. I would love to see that happen. The bigger problem, Tony, I think it is, that I see is how much work it takes to get these bills through, right? Like I completely agree that there's a lot of great work happening. The energy it takes to get that great work to go through the legislative system, to go through the administration, is too much. That tells me we might not be as ready as we say we are, given how much advocates have to work to push through the SB 855s, the 221s, and hopefully the 283s, right? Those take a lot of labor. They are labor intensive. There's a lot of fighting that's done, particularly with health plans, to get these things through. So it's not a simple process like, oh yeah, that's a great idea. We should, have better parity, and we should just make that so. So I think it's a bigger conversation of how much work it takes to get a lot of these bills through, and I think that's part of the frustration too. I think, it's absolutely right. There's a lot of things. That slide that Chris showed, the amount of labor it took to get those things through is unconscionable, to be frank.
Yeah. Can I add? So this is my former Impact National Center for Youth Law, as an organization who sued the state, right, for KDA. We're still trying to implement that, right? So how do we work with, and Katie Harrod, I don't know if she's here or not, it's like, I think my gift has always been in the in-between, right? There is a lot in implementation that should be happening. I can SB all the time, and you can do the political will, and a lot of energy gets wasted in that. But then there's also this opportunity to work within the system that I really want to be, I am in this role because I believe in that possibility, right? Because we sued the state, it didn't work. We're still working it out. We staffed legislation on segments. It didn't, and I'm saying it didn't work. It kind of didn't work. We're still Medicaid. Well, I'll believe that, Chris. But there's no other options because we haven't shored up less invasive treatment for our children in foster care. Right? What is it working within the system and understanding all the challenges and opportunities? Can we have an open conversation with administration about how do we implement the really great things that we have on the books, whether or not we had to get sued for it or whether or not we had to pass legislation? Can we get that to work in the first place?
Yeah. And I'll even give a great example. Many of us here worked really hard to get trauma screenings implemented and done, not just in Medi-Cal, but also in private coverage. And that was something the administration supported. That was something legislators supported. It was quote unquote easy. And we're hearing that health plans are sending consumers bills for trauma screening. So, when we talk about political will, it's not always just our elected officials, our policymakers. Sometimes it's even the stakeholders involved in the process. So now, as advocates, we have to spend time going back saying, can health plans do this? With health plans, are they bad actors? And there's so much stuff that you have to do to get these things done that I understand why it takes so long to get to the hard stuff.
Yeah. Implementation matters.
Hi, friends. I'm Sarah Crow, Managing Director of the First Five Center for Children's Policy, First Five Association of California. I really appreciate this panel. Thank you all so much. I agree with you and share your observation that youth are blunt about what they want and their mental health needs, and they have a different kind of vernacular about it than we did growing up. And I'm curious if you're finding that parents of very little children, infants and toddlers, are similarly blunt about the needs of infants and toddlers and the mental health needs that their families need, given how important as you all know, the importance of brain development in the earliest years.
That's me. So based on kind of our work in the campaign world, I don't think they have the words and the articulation for it. Right, I mean, I've been on this roadshow of interviewing ethnic media up and down the state, and it's really just about educating. Right, what does that mean? I mean, it's one of the interview questions is, do you believe that that the babies felt that the trauma of the pandemic? Yes, they did. Right, the fact that just kind of beginning to, I didn't mean to make that. I'm very passionate about this issue. Can you tell? Can you tell? And so I think it's about the words, and the stigma is a really deep thing when we're actually talking about communities, making it accessible. So it is really part of us, as you know, Sarah, is one of our biggest levers in First Five California is our media campaign. Really, what are we how are we talking about, how are we changing the world? So there's an openness to accessing, even kind of articulating the needs of their babies and themselves, quite frankly. So in our focus groups, no, they They are blunt in a different way, but they're also raised from old school kind of values around behavioral mental health.
I'll also just add really briefly, I think that there is a level of shame that parents of young children have, that they have internalized when they think they aren't giving their baby the right things, right? So that cannot be underestimated. And that shame, I've noticed, is greater for parents of young kids than parents of, say, school-age children for a variety of different reasons. But that's also what's prohibiting or inhibiting the ability to really talk about what's needed.
And I would just add, thanks for the question, Sarah. I think what we've heard from parents, including parents of very young children, which we did do some focus groups with, maybe not the specific request for a specific type of service, but just the general challenge of access and navigation. Like, they know they need something, and maybe they can't name what that specific, clinical support is, or I need this kind of consultation or this kind of therapy, but the feeling of like every door I knock on or number I call, I get referred to another place, versus somebody who actually helps me access and navigate to get what I need. And I don't think that's unique to parents with young children, but I think that was definitely something that we heard. And obviously something we're working on, but have a lot more work to do. And that it also applies to even existing resources. Some of it is we don't have enough resources, right? And so we have to build up the workforce. There are other things we have to do to make more services available. But some of it is even just navigating to resources that do exist even today.
Hello. Okay. Hi. Thank you all so much for being here and speaking as a panelist. I'm Christine, and I'm an undergraduate public health student at UC Berkeley, but I worked in a nonprofit legal clinic that addresses and supports parents who lost their children through the Child Protective Services, and with like CYBHI and all these other programs kind of addressing meeting students where they are through schools. I was wondering if there are, if you all are doing any work regarding and addressing Child Protective Services and how that mandated reporter position for bus drivers, teachers, and staffs involved kind of can affect the disparity of how much help these students want to get or have access to, just because like anything they disclose can be hugely, greatly detrimental to their family health.
Yeah, really appreciate that question. Interested to hear if my colleagues on the panel want to share anything on it. Yes, and as you probably know, both parents but also youth are also very, very well aware of those mandated reporter requirements. And youth told us specifically, this came up particularly a lot related to substance use disorder, either their own or in the context of their family. And so I think this is a really significant issue that we have to think about how to address disclosure so that we can get people the supports that they need. And one of the things we are working on is how do we, for example, connect some of the work of CYBHI with the system of care work that's happening related to youth in foster care, where a lot of those conversations are happening about how systems need to better work together, and then how do we bring some of the assets of the CYBHI, for example, as I talked about, the real focus on increasing access to school-linked behavioral health services, and that includes the fee schedule isn't done, but it is intended to include all the way from prevention to treatment, as I mentioned. So how do we think about what those services should be that we can make more accessible to kids in school so that they may not have to enter other systems? So how is it that we actually connect across those initiatives? So I do think it's a really important issue, and as you raised, parents and students are very aware of that. We've also had a really strong request from many of our partners, but particularly our education partners, to address the intersection of HIPAA and FERPA, which also connects to these issues. And so we are working on hopefully a process that will come together to provide some guidance around those issues to the field.
Over here, if you all don't mind. I know maybe you can wrap your answer to this one together with it.
Hi, everyone. My name is Kenna Chick. I actually worked in peer support for a number of years and ran a peer support chat line. And one of the areas that I really noticed in this space was that a lot of youth that were connecting to the chat line were talking about their experiences in being afraid to connect with the mental health system, not simply because of stigma, but because of the fear of lack of control of what's going to happen next. Will they be forcibly hospitalized? Will their teachers know about it? Will their parents know about it? And so I would be curious to hear whether there's any initiatives or conversations in any of these children and youth initiatives around how we can best protect around that, and also ensure that we are educating people when they're navigating the mental health systems, so they know how these systems work and what they can do to really get their needs met in a way that's respectful to them, as opposed to kind of just maybe hold off on care until we figure out what the system looks like. Thank you.
Okay. I'll let my colleagues add. I'll start. So in that Youth at the Center report, one of the things you'll see is youth specifically said to us, we want self-determination, not empowerment. Like, quit trying to empower us. We have power. We want self-determination. And so, for example, actually, one of the areas where this is coming up is actually in the context of designing this virtual services platform. Because, for example, if we are to help a youth get connected to services in their community that they may want and need, they're going to have to tell us who they are, right? They're going to have to disclose certain information. But in the work with youth, they've actually been very clear. Some of them do not want to have to disclose any information, and they want to be able to get access to certain kinds of resources and supports without having to sign up for anything. And so that is part of the work that we're figuring out. Just as an example, it's one example of sort of the design aspect of that. How do we connect youth to different kinds of information, resources, tools that they want, that they are asking for, but in a way that is respecting what they are telling us, like how they want to go about doing that, and that they are deciding when the system is trustworthy enough for them to share other information that might allow them to be connected to other kinds of resources. So that's an incomplete answer, but sort of as an example, I think this, I guess I want to acknowledge it as an issue that has come up not only in terms of youth voice, but in the actual design and planning of different aspects of the initiative that we have to think about. Another place where it has come up is youth were very clear in the focus groups that we're really explicit that the Children Youth Behavioral Health Initiative, that behavioral health is meant to include both mental health and substance use, not just mental health. But youth have also said to us, if I'm on a school campus where there's a zero tolerance policy for drugs, and you said in there are school resource officers where I've seen them interacting with other students over substance use, you know, I'm probably not going to go to the wellness center and tell somebody that I am having a challenge and I need to find resources. And so I think we have to find ways for them to decide who they're going to share with so that they can get access to the services that they're looking for. And that means providing probably more than one pathway to some of the services and supports that youth are looking for.
And that's why Children Now is co-sponsoring with the Alliance and the California Youth Empowerment Network a bill that actually would provide a public health framework to help school officials figure out what to do when there are drugs on campus that don't involve suspensions and expulsions. Had to get that in really quickly.
All right, Jackie, last statement.
Oh, no.
And it's a wrap. We gotta
Oh,
get
no,
out
no,
of
no,
here.
no. I was like, and law enforcement loves that one, right?
Sure.
Adrienne, good luck. First things first, there's an AB 2083 report that has been issued or is out already. And that is actually the plan of created by Department of Education, Department of Social Services on kind of mental health work. Just what's interesting enough that we've actually had conversation with CDSS, and children 0 to 5 actually have kind of really disturbing outcomes, if you will, that we need to kind of unpack really intentionally. So just be really clear, half of the children in foster care are 0 to 5, and the findings there are there clearly is a need for treatment and support for them. And the other thing, again, there's impact litigation, right? Informed consent, at the age of 12, they can actually access these services and have their identities protected. But I also kind of understand, you're not going to go to the wellness center if there's an SRO on campus. So multiple pathways, I support that.
Big hand for our panelists.
Good job, always. Good job, always.
We're like,
I do have some paper copies of those reports. I'll just put them up here maybe on the chairs in case anybody's interested.